So Dr. Vikram Patel, again, is the Pershing Square Professor of Global Health at Harvard Medical School and co-founder, I was mentioning, of Sangath, an Indian NGO, non-governmental organization, which won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008, and the WHO, the World Health Organization's Public Health Champion of India Award in 2016. He's also co-chair of the Lancet Commission on Reimagining India's Health System. And his work over his career has really focused on the burden of mental health problems across the life course, their association with social disadvantage, the use of community resources, prevention and treatment. I heard him speak at the APA this past year and found it just really fascinating and really important for us to learn from all his work of global mental health and how that can actually apply to the US in solving our own problems. So he's going to speak about scaling up psychosocial intervention for mental health problems from a global perspective, as well as what we can learn in the US. So please welcome Dr. Vikram Patel. Thanks so much.
Thank you very much, Professor Rosenfield. Paul, if I may. Thank you very much for inviting me to speak with this community today. I'm delighted to be here, although I would have preferred to be in person, but I guess this is the new world that we all inhabit. So I'm going to swing straight into my talk, and then I hope there will be enough time for us to have some discussion as well about my presentation. So I'm going to be focusing my talk on psychosocial interventions. In a moment, I'll explain to you what they are, but also using my talk not only to refer to the work that has been done in the Global South, which is where a lot of the real innovation and scaling up has taken place over the last decade, but then spend the second half of my talk really referring to an initiative that I've launched at Harvard Medical School that is seeking to scale up this very exciting implementation science globally, both in the Global South, but also very importantly here in the US. So just a brief word about psychosocial interventions. I'm sure all of you will be very familiar with what I'm talking about, but nevertheless, just to confirm that we're all on the same page, psychosocial interventions are interventions for people with mental health problems that target two quite distinct mechanisms: psychological mechanisms or social mechanisms. And I won't go into any details about those different kinds of mechanisms. There are many of them. Nevertheless, that's what psychosocial interventions are. Oftentimes, packages of care really combine these two different kinds of mechanisms, which is why I have referred to these as psychosocial interventions in this talk. What's the evidence on their effectiveness? Well, it's extremely robust. It would be fair to say that when you look at these different mental health conditions for which psychosocial interventions are indicated, either as first line or the most effective treatment for many conditions, or enhancing the effectiveness of pharmacotherapy for certain conditions, or indeed, as in the case of depression, where you have a choice between medication and psychosocial interventions, as the latest network meta-analysis in World Psychiatry shows, psychological or psychosocial interventions outperform medication when it comes to long-term outcomes of recovery through lower relapse rates. When you consider this list, you will soon come to the conclusion that there isn't actually any individual with a mental health problem who may not benefit from a psychosocial intervention. So put conversely, psychosocial interventions are relevant in the management of every single case of a mental health problem. So with that robust evidence that comes from hundreds and hundreds of randomized controlled trials and lots of meta-analyses and so on, that's not really the substance of my talk today. The substance of my talk today is, given that we have such effective interventions targeting psychological and social mechanisms, and that they outperform most medication interventions for common mental health problems, how well are we faring in terms of access to these interventions in different parts of the world? And let me start with the US, a country that we all work in, but also a country which has more mental health specialists, mental health human resources, and dollars spent per capita than any other country in the world. And therefore, one would expect that in the US, we should have, as a consequence of this large number of mental health professionals and spending, reasonably good access to quality care. And by quality, we mean access to evidence-based interventions. Well, it turns out that only about a quarter of those individuals who are seeking care for depression or with an acute depressive episode, only a quarter actually receive psychological treatments, in contrast to 90% receiving medication. Of course, much of this is happening in the primary care context. What's especially worrying is that people who come from low-income and minority groups overwhelmingly express a preference for psychosocial interventions, but ironically are even less likely than the quarter that's the average to receive them. And those of us who are clinicians won't be surprised to read this final point, which is that when people get what they want, their preferred treatment, they engage better and they therefore do better with the long-term clinical outcomes that everyone wishes to achieve. Now, I often ask people to do a thought experiment and imagine, we were talking here about breast cancer. Imagine you had two different interventions for breast cancer. Intervention A was associated with lower relapse rates. It was more preferred by women, especially women who came from low income and minority groups. Intervention B was as good as intervention A for remission, but had worse outcomes in terms of relapse rates and was less preferred by women. Can you countenance a situation where the health system would only make intervention B available? Well, that's precisely what is the case for many mental health problems in the US. And indeed, globally, the situation is even worse, where there's virtually 0% coverage of most of the world's population. And this is why I think when Tom Insel wrote his recent book on the state of mental health in the US, what he describes in his book is not a crisis of the lack of political will. It's not a crisis of the lack of money. It's not a crisis of the lack of knowledge, because we have got knowledge, in this instance, knowledge that goes back half a century. It is actually a crisis of care. The fact that we do not deliver interventions that we know work to the vast majority of people who could benefit from them. So what's the opportunity? The opportunity comes largely thanks to Tom Insel's own leadership, really, when he was the director of the National Institute for Mental Health in about 2009. He approached me to co-chair the scientific advisory board of the grand challenges in global mental health. The other co-chair was Pamela Collins. And the two of us were assigned the task of identifying the leading research priorities in the global context, which, if the NIMH or other research funders invested in, could shift the needle on the burden of suffering of mental health problems in a fairly short-term scale of time. So we constructed a classic research priority setting methodology with a Delphi panel, nearly 400 experts, comprising a whole range of disciplines concerned with mental health, from neuroscience through to implementation science, but also policymakers and people with a lived experience from around the world. And in a multi-stage research priority setting exercise, published the 25 leading research priorities in this commentary paper in Nature. It didn't come as a surprise to me, but certainly was a surprise to many of our colleagues, that these 25 research questions, not one of them comprised a fundamental basic discovery question. For example, a new molecule or a new gene for a particular mental health condition. All these questions were really about implementation. How can we do better with the knowledge we already have? How can we ensure that more people who can benefit from this knowledge are actually benefiting in the real world? Over the last 10 odd years, the NIMH and a range of other both global and national funders have been investing heavily in research questions that are framed around the grand challenges in global mental health. My back of the envelope calculation suggests that more than $1 billion of new money has been made available. And thanks to this large investment, I can tell you today something I couldn't have said in 2011 with great confidence, thanks to more than 100 randomized controlled trials from more than 30 low and middle income countries. In fact, that number has already increased. It's increasing almost every week as more trials are being published from different parts of the world, that we know how to deliver clinical and preventive interventions, psychosocial interventions in any resource setting. And an example of the resource setting is the one that is shown in the image on this slide, where you can see two women. The woman on the left is a mother with postnatal depression. The woman on the right is a provider who is providing a 6-session CBT-informed intervention, but primarily focused on problem solving, on this bench that has been erected in the compound of a primary health center that is located here at the back in the city of Harare in Zimbabwe. Now, this provider may look like she's a nurse, but in fact, she's a grandmother with no prior mental health training who lives in the local community. And, you know, grandmothers like to get involved with everyone else's business. So this particular interest of grandmothers was redeployed to becoming a provider of mental health care for people in their own communities. The other interesting thing about Zimbabwe's cultural norms is that older adults are highly respected as repositories of wisdom in their community. So the grandmother is not only somebody who is living in that community, interested in the well-being of others in that community, but is also someone who's highly respected. So this particular characteristic was built upon by Dixon Chibanda and his team to design an intervention delivered by these grandmothers, and then to deliver it in this bench outside the clinic, mainly because the weather is great in Zimbabwe around the year, but also because the clinic, as you can see at the back, is so busy. There are people hanging around outside because there's no place inside, that it's hard to deliver a psychological intervention in such an environment. So he constructed this bench. And you know, this has become a very well-known model of care called the friendship bench, but he also ran a randomized controlled trial, one of the 100, demonstrating the effectiveness of this approach in recovery for people with mental health problems, depression in this case. I've been working with a similar organization in India, Sangath, for the last decade and a half. And as you can see the titles of all these trial papers that are published here, you will notice that the organization is pretty agnostic in terms of which mental health problem it deals with, from depression, anxiety, through to autism, psychosis, and drinking problems. And it's also pretty agnostic about whether it's about prevention, treatment, or recovery outcomes. And so you can see, and this is just a sample of the very many randomized controlled trials that Sangath has led in partnership with international institutions, including Harvard Medical School, where I work now. And these are all trials published in leading journals. Most of them, in fact, have been published in the Lancet, but also in journals like PLOS Medicine and JAMA Psychiatry. And this is, again, a part of this large body of implementation science that I referred to earlier that has completely transformed our understanding of what mental health care looks like and how it should be delivered. You can find more details about the content of these interventions and how they're delivered in these two systematic reviews. The one on the left focuses on the care of people with serious mental illnesses like schizophrenia, enduring mental illnesses, and the one on the right focuses on mental health conditions that are primarily in the mood, anxiety, and trauma spectrum. As you might imagine, those individuals with psychotic conditions and long-term psychotic conditions tend to have more psychosocial interventions that target social mechanisms, whereas those individuals who have mood, anxiety, and trauma-related conditions tend to have interventions that are primarily targeting skills building through brief psychological treatments. So as I mentioned, this large body of evidence has really helped us redefine and reframe mental health care in 4 very important ways. First of all, what comprises a mental health intervention? We are now able to demonstrate that while around the world, the most common intervention a person will receive is a pill, whether they actually need it or not, actually, there are alternatives. And those alternatives are brief interventions ranging from as little as 1 session, a single session of a carefully crafted intervention. In fact, Jessica Schleider here in the US at Stony Brook runs perhaps one of the most innovative labs examining how single session interventions should be designed and constructed and delivered. But you see similar work happening in the global context. But even the longest interventions are rarely more than 6 sessions. They're typically combining both skills building and or altering the social world of the individual, again, through building social skills. Oftentimes, these are both occurring together, but also helping the individual navigate to social welfare needs, because as we all know, social factors often coexist with mental health problems, and addressing only the symptoms is less likely to lead to long-term recovery as compared to when you also concomitantly address the social issues that they're facing. The interventions are delivered where people are, not where the providers are. Typically, this is in primary healthcare centers, but also in my own work in home-based delivery. Of course, these days, thanks to telemedicine, that home-based delivery can also be done on a digital platform and not necessarily in person. Another good example of a context, particularly for young people, is in schools and educational institutions. The interventions can be delivered by whoever is authorized, like or has the time or is available in the community. The key is availability. Typically, the providers are those who are widely available in the community and either have a motivation to care for others like grandmothers or have a mandate to do so like community health workers. But the key here, of course, is we're flipping the narrative from the narrative that we often hear, which is a very nihilistic one, which is that we don't have enough resources, to changing the narrative to how do we use the resources that every community has, people who care for one another, towards the essential task of mental health care. And lastly, the how. It's really important for me to emphasize here that we're not talking about a separate mental health care system, but an expansion of the existing, of the footprint of the existing specialist mental health care system deep into the community so that it reaches the last mile, and in doing so also addresses historic disparities in the access to quality care. And thus the real delivery model that I champion is that of collaborative care, in which the frontline worker, the community health worker, the peer support worker, the nurse who's working in the community, whatever that provider might be, is working as a member of a team that almost always will involve a prescriber and preferably a mental health specialist if that person is available in a collaborative care model. You know, about 15 years ago, I couldn't give a talk like this to policymakers or to an audience like yours because it would have just been ideological with no empirical science. Today, that empirical science is so robust that it has now begun to inform policies and practices around the world. Here you can see examples of reports or recommendations from two global agencies, the World Health Organization and the World Bank, as well as at the national level, the National Mental Health Policy of India and the RAND Corporation's report on how to transform the US mental health care system, published just last year. And all of these are really focusing on building the frontline workforce. I'm sure all of you are hearing the word workforce all the time, including from the Biden administration, from state governments in the US. The key point is the building of the workforce at the level of the foundations of the mental health care system, which is, of course, at the community level, through community health workers, peer support workers, and others, to deliver brief, evidence-based psychosocial interventions for mental health problems. The question now isn't whether this approach works, but how do we scale up? And I want to now, therefore, move on to the second part of my talk, which is the initiative that I launched at Harvard Medical School 3 years ago. But before I do that, I think it is important to remember that scaling up psychosocial interventions are particularly complicated for two reasons. First of all, there's no money in it. There is no commercial industry that has anything to profit from psychosocial interventions, in complete contrast to medication. And therefore, it requires us as a community of mental health professionals, public health professionals, to advocate and actually demand resources for the scaling up of these interventions, because the natural market forces do not actually apply to psychosocial interventions. And the second important challenge is that the traditional methods that have been used for training and supervision, which is expert-led, in person, is simply not scalable in the real world when we have to train hundreds of thousands of frontline workers across the world and in the US to deliver these interventions. These approaches that have been used historically and in randomized controlled trials are really not scalable. And therefore, we have to think about scalable approaches for training, supervision, and quality assurance. And this is really the goal of the Empower Initiative, which is to build the frontline workforce to deliver mental health care by deploying digital technologies for learning, mastering, and delivering quality-assured psychosocial interventions. Our mission is pretty ambitious. It's to empower anyone, anywhere to master the delivery of evidence-based psychosocial interventions. And we've evolved a series of different principles and methods that enables us to do so with a great degree of transparency and replicability. First of all, and this is the most important step, is the selection of the intervention. We will only work with interventions that are clearly described in manuals that are non-proprietary, that are based on systematic reviews of effective interventions, and are mechanistically informed through targeting specific psychological skills such as behavioral activation for depression, or social skills such as building interpersonal relationships with others, or befriending interventions as an example in that context. And for each intervention, we constitute an international group of advisors who really represent primarily the experts, the subject experts in that particular intervention and or mental health condition, before we will then say we're ready to move forward to the next step, which is the step of scaling this up, which I'll explain to you in a moment. Based on this, we've identified a set of different interventions that are ripe for scaling up, and we really adopt a staging approach here, a dimensional approach to mental health care. So at the level of the general population, an intervention that targets people who are developing distressing mental health symptoms, with the primary goal of prevention, a single encounter intervention that really is promoting rapid resolution of those symptoms by focusing on garnering social support, psychoeducation, and promoting social connectedness. This is the kind of single encounter intervention that I was speaking about earlier, that we believe everyone in the community, but certainly all health workers, should be competent to deliver. That, of course, will not be sufficient for many people who will develop more enduring symptoms. And so the next set of interventions focus on early intervention in the form of brief psychosocial interventions that are really now focusing on building psychological skills. This is going to be primarily focused on frontline workers, such as, for example, community health workers. And I'm going to give you examples of two of these programs in a moment. That will not be enough for everyone either, and there will be therefore an increasingly diminishing group of people who will need more specialized care and will need to see a psychiatrist or a psychologist, and may even need a period of being in hospital. But then when they're discharged from that care, they have long-term needs to promote recovery, to reduce the risk of relapse. And so that's a third set of interventions that are really addressing social determinants and building coping skills and supporting family members towards the ultimate goal of recovery. And a good example of an audience for this group of interventions are peer support workers. The second set of principles and methods is the deployment and development of digital products for those interventions. We've designed, with NIH support, a systematic methodology of blueprinting and scripting a competency-based curricula from those manuals. Assessment of competencies, both of knowledge as well as of skills, using structured role plays with ratings using the World Health Organization's EQUIP tools. And of course, always co-production with target audiences and reviews from diverse stakeholder groups, such as, for example, in the case of our work with school counselors, the audience would be people who work in schools in providing frontline care for mental health problems in adolescents. And the final set of principles and methods is about how we then implement and evaluate this further. We implement through partners on the ground who have already deployed existing human resources. So these are not research projects, but these are real-world scale-up, and that requires having strong implementation agencies like governments, hospitals, and other implementation partners who already have existing human resources. In a moment, I'll show you our accompaniment model that goes well beyond training. The idea being that this is a lifelong journey for frontline workers, not only to learn a new intervention, but to master it and to assure the quality of the delivery in the long term. And over the next month or so, we will soon be launching, in association with Harvard Medical School, an independent social enterprise that will be able to scale up the digital products in partnership with governments and other implementation organizations. So I mentioned the accompaniment model. This is, of course, a term that my late department chair, Paul Farmer, coined. I find it a very evocative term. He will often speak about the role of accompanying a person with a health problem on their journey to recovery. But we apply the same idea of accompaniment on accompanying the frontline worker on a lifelong journey of learning, delivering, and mastering care. So imagine for a moment we have a naive learner, let's say a community health worker. The community health worker undergoes a competency-based course to learn behavioral activation for depression. The individual then completes a competency assessment of knowledge. But of course, we all know that you can't really learn any skill by simply sitting in front of a computer. The next stage is an internship stage in which the individual now begins to see patients with depression, but under supervision of an expert, which is done remotely. And after completing a minimal amount of casework, will then do a skills-based competency assessment, which then ultimately leads to credentialing. Once credentialed, that individual will join other community health workers who have also similarly completed credentialing, and then will participate in continuing measurement-based peer supervision, ultimately maturing or graduating into an expert who can then support the next generation of learners. In other words, the accompaniment model means we accompany the learner on a lifelong journey, but similarly, one could also have a similar approach to accompanying the system on a lifelong journey with continuing cycles of reporting, evaluating, and refinement in the classic sort of quality improvement cycles that many of you will be familiar with. Technologies are deployed in a number of different ways. Currently, these are some of the ways we deploy technology. First of all, of course, the digitally delivered competency curriculum, almost entirely video-based, which can be delivered on any learning management system. Remotely delivered competency assessments, the knowledge ones, of course, are self-explanatory, but we're also designing ways in which role plays could be delivered through remote platforms with psychometrically validated measures. We have designed with the Boston-based tech company Dimagi, which is the world's largest community health worker support technology company, which also works in the US for the COVID-19 containment work. We've designed with NIH support and support from the NIH equivalent in Canada, a bespoke digital app for measurement-based peer supervision that offers quantifiable ratings of therapy quality. And we're working with our School of Engineering and Applied Sciences lab on computing and society to develop data science-driven protocols that can harness the digital footprints of training to competencies to quality of care and ultimately link to patient outcomes. For example, to unpack what the training trajectories are, who might need more support so that proactively we can support people who might likely need it using the data of completed training, but also to unpack the black box of psychosocial interventions so that we can identify which quality metrics predict patient outcomes and then focus on those quality metrics in the training and in the supervision so that we're continuously enhancing the effectiveness of the whole program. I want to end with a couple of examples. I want to just demonstrate how this is happening. It's only 3 years old. We're in early days of the scale up. We couldn't have even done this had we not had this decade of science that has informed the scale up. So it's very, very preliminary, but this is where we are right now. The story begins in this case with a 6-session BA treatment for severe depression that I developed with the team in India, ran a large randomized controlled trial in primary care demonstrating the effectiveness, and I'll show you the results in a moment. This was replicated in Nepal and indeed is now been adapted for use with perinatal populations in North America in a large PCORI-funded trial being run in UNC, the University of Chicago, and the University of Toronto, with the PI being Daisy Singla. And so the intervention has already, in fact, been adapted for use in North America. The intervention was adapted because of the incredible results that BA has shown to produce, both in the formal evaluations with mental health professionals in the US, but also in this instance with lay health workers in India. Here you can see the trial cohort outcomes in the medium as well as the extreme long term. 100% of the individuals entering the trial was severely depressed at the time of enrollment. At the time of the 3-month primary endpoint, 2/3 had recovered. These are people with severe depression, PHQ-9s of 15 and above, as compared to about, the fraction remained depressed were 2/3 in the control arm. The fraction who were depressed in the intervention arm was only 1/3. At 12 months, you saw a sustaining of those remission rates, implying that 2/3 had now recovered. Incredibly, 5 years later, after a 6-session treatment delivered 5 years earlier for people with severe depression, those recovery outcomes had been sustained. 2/3 remained well. This suggests two things: that 2/3 of people with severe depression did not need anything more than a 6-session treatment of BA by a lay health worker. But it also says that 1/3 needed something more. And this shows how a one-size-fits-all approach cannot work at a population level. What we need, therefore, is a collaborative care model. The majority of individuals do not need to see a specialist, but there is a very vulnerable and important subgroup who do, and we need to figure out delivery systems that allow us to ensure that people get a step care approach, so that this 1/3 that did not respond ideally should have been seen by a specialist. Unfortunately, the place we work in did not have that collaborative care model, making it extremely hard to do so. Based on this work, the NIH gave us a R01 grant that allowed us to then begin to develop the methodology for developing competency-based online curricula. And we've just completed a randomized controlled trial comparing 2 digital training models, one with and one without coaching, with the gold standard of expert-led in-person training. And we're in the process of writing these up. These are preliminary results demonstrating that there were gains in competency across all 3 arms, that all 3 arms had similar gains in competency, indicating that there was no difference between the digital training and the expert-led in-person training. With support from Grand Challenges Canada, we have completed the design and testing of a measurement-based peer supervision app that's being currently tested in India, and an NIH grant is allowing us to do the same work in the US. What you can see here is on this app, a frontline worker can enter information about the depression scores in the individual, can then record a therapy session, can then listen to the therapy session of one of their peers, and can use a checklist that is specific to BA to then rate the quality of that session. As you can see here, these are the kind of scores. The scores can be rated for your own session, an expert can rate them, or your peers can rate them. And these are then used for the peer supervision, both allowing an individual frontline worker to develop their own log of the quality of care, but also use this as a way for continuous learning. As I speak, more than 1,000 frontline workers in India, in a rural part of central India, have now completed this journey of learning, are now mastering the delivery. And I was just speaking to my colleagues in India yesterday, and in the last 2 months alone, 7,000 new patients of depression have been identified and are now receiving this brief BA treatment. Mind you, this is only the first 2 months of the scale-up in central India. I came to the US in 2017, and of course, I discovered that I was in a developing country myself. I say this obviously tongue-in-cheek, but certainly when it comes to mental health care, I'm sure all of you will agree the US has a lot to do to fix its own mental health care system. And so I was delighted to have the opportunity for the first time unexpectedly to bring the work that I was involved with in Africa and South Asia to the US. I had a fortuitous meeting with a couple of key people who have now become key collaborators. Arthur Evans, who's the CEO of the American Psychological Association, and Andy Keller, who is the director of the Meadows Mental Health Policy Institute in Texas. And together with them, and with support from a philanthropy, we began the task of adapting these curricula for use in the US. And this is an unusual process in and of itself. Typically, you hear of things developed in the US being taken elsewhere. I think this was a pretty novel experiment for all of us, that we were taking something developed in a foreign language in a developing country and adapting it for use in the US. We were lucky in last year. There was a call for applications for what was called the Lone Star Prize from Texan philanthropists to transform the lives of Texans affected by the pandemic. We put in a bid to bring these curricula to scale through community health workers in Texas, and we're delighted in the face of the stiff competition we had from a number of other great ideas that our proposal was funded. And so as I speak now, the first batch of community health workers working with the Baylor-Scott-White system are learning these interventions. And over the coming year, we hope that we will gradually expand our footprint in Texas, also working with faith-based organizations, working in close collaboration with the hospital systems, such as, for example, Dell Medical School in Austin, JPS, as well as the Baylor-Scott-White system in Texas. Another example is on mood and anxiety conditions in adolescents, using a brief problem-solving intervention that we designed and tested in India, and is now being scaled up in India through an online learning. And this is just showing some screenshots. But again, to the point about reverse engineering and bringing it to the US, we're delighted that the Manton Foundation has supported a similar program of adaptation and scaling up in the US, led by my colleague John Weiss, who many of you will know is a very prominent psychological treatment scientist focusing on his work on adolescents, and Jamie Young at the Children's Hospital of Philadelphia, along with Tammy Benton, who's a child and adolescent psychiatrist. We've joined forces together working with a number of national guilds to develop the curricula for school counselors and other frontline workers working with adolescents. And we're really basing our treatment selection process through John's pioneering work on dismantling complex interventions into the active ingredients of what he calls principles of treatment mechanisms. And you can see his framework called FIRST shown on this slide. And I want to end by simply saying, this is a unique opportunity for us. I think we'll all agree that this is a historic opportunity as well. Never before has mental health been so much in the in the eyes and the spotlight of policymakers, both nationally and globally. There is a great felt need for transforming mental health care systems. I believe that the rich investment in science that the NIMH and others have made over the last 15 years have borne tremendous fruit here by demonstrating how these interventions can be made very brief and mechanistically informed to enhance their scalability, but also how they can be delivered by frontline workers who are available in every community. What Empower is seeking to do is to scale these up by deploying digital tools and products so that we can very rapidly train a frontline workforce to learn, master, deliver, and ultimately evaluate the impact of what we do. Thank you very much, and I look forward to questions from all of you. I'll hand back to you, Professor Rosenfield.
Thank you so much. This is really exciting work and so fascinating, and I think we have a lot to learn here. So let's open up to questions. People can either raise your hand or put a question in the chat, and I will unmute you if you'd like to ask a question. You can't unmute yourselves, so it was our security effort. So any questions? I'm curious myself, just the Center for Practice Innovations at Columbia does something a little bit like this in terms of videos, training peers, using videos to train a larger segment of the population of sort of mental health providers. And I'm wondering if you can comment on sort of, is that a different project, sort of training more established mental health workers versus what you're doing, which is expanding to non-mental health workers as well?
Well, I think these are all wonderful examples of how different groups around the country are actually trying to scale up frontline worker delivered intervention. So I wouldn't say they're altogether different. There are some nuances and differences. So, for example, in our instance, we see training only as the first step on a lifelong journey. I'm not absolutely familiar with the model in Colombia. We essentially have a kind of a relationship that we build with the learner, but particularly through the system that is employing those learners. So, as I showed you the accompaniment model, we think that really what's critical here is quality of care. And quality of care, of course, is something that requires a very different approach. How do you measure quality of care in a quantifiable way, which is transparent? And so these go well beyond training, and the use of data science protocols that allow us also to generate very useful information, both from a scientific perspective, like I said, which quality metric really matters, but also from an impact evaluation perspective. But there's a lot we can learn from one another, and it's exciting. Right now, so many agencies from SAMHSA to the HRSA and others are all speaking about building the workforce. They're all in different stages of conversations with me, and I'm sure many other groups around the US. What I think is really exciting right now, Paul, is that there is no longer a question that people are asking: is this safe? Is this effective? People are now asking questions that are much more around implementation at scale. How do we actually take the science out? 10 years ago, I remember speaking when there were just 2 or 3 trials. The first few trials were published in 2003. So it's a pretty new body of science, I have to say. But back then, I remember when I would speak, to different audiences, there would be a huge pushback from, not least the professional bodies. Today, the professional bodies are embracing this. The professional journals are embracing it. So this is to me, this is a very important shift. And I don't think that shift could have happened had we not had this massive body of science that demonstrates the safety and effectiveness of these approaches.
Great. So we have Dr. Ala Prokovnik Rafik, who you can just ask your question verbally if you'd like.
Yeah, sure. Thank you so much. This is an incredible presentation and really eye-opening. A number of Boston-based clinicians and myself are currently working on a community-based curriculum to address training and trauma care in Ukraine. So this model is absolutely amazing, but do you think it could be applied in areas of high conflict where external circumstances are regularly changing?
Well, I would think, first of all, thank you, Ala. First of all, just to say, since you're in Boston, we should meet. But it's important for me to also say that in Massachusetts, the Blue Cross has actually started supporting this. So the Blue Cross, which is the largest, insurance provider in the state, has actually started working with Partners in Health, which is a big Boston-based not-for-profit organization. And I'm speaking to the CEO of Blue Cross, in fact, on Friday, because they have now embraced the idea of community health worker-delivered psychosocial intervention and want to finance it. So I think there's a huge amount of interest here. What I will say about conflict situations is I think this is particularly relevant because actually this is where it's we need to scale up so quickly. And that kind of old-fashioned model of flying people down, into the conflict zone to provide care is just so complicated and not scalable. So I think it's, if anything, even more relevant for refugee, mobile, and conflict-affected populations, as it is, in fact, for communities that are more stable.
Barbara Warren has a question from the audience. Barbara.
Right. Yeah. Thank you so much, Dr. Patel. Just a qualification here. I'm a psychologist, although I work in the Office for Diversity, Equity, and Inclusion at Mount Sinai and teach in the medical school. And I loved everything that you had to say. My question is, and I'm glad you mentioned SAMHSA because I also sit on the National Advisory Council for SAMHSA, and we've been very involved in supporting exactly what you've been talking about at the federal level. My question to you is your definition of, or what's a definition of peer? You probably are aware, or maybe you're not, I don't know, that for a long time now, New York State's Office of Mental Health has a certification program for peer recovery support. But the definition of peer is very, very narrow. You have to attest to, and in some way demonstrate that you are a peer because you yourself are in recovery from the condition for which you're being trained. And there is a training, a very training curriculum that's been evaluated that you have to go through. You have to have a certain amount of supervision. And they've been scaling this up in New York State, particularly for mental health issues, because the other qualification for being a peer in the particular issue that you are being trained to help people with is that it's compensated. It's covered by insurance. It's reimbursable. And I think that's the other issue too, in terms of frontline workers, particularly people who are not medical or mental health professionals with a particular license, the issue of reimbursement in order to sustain these services. So I'm wondering what your thoughts are about.
Yeah, well, Barbara, thank you so much for bringing up this issue. You know, the peer support work is something that I am so excited about because it's already happening in the US. I know that New York isn't the only state. There are peer support workers who are being reimbursed in many parts of the country. And what we're hoping to do in the coming year is to connect with all of these different groups, to look at the curricula, to look at the eligibility criteria, and to devise something that is based on experience on what the curriculum should be going forward for places where it's not already happening. You know, different places have somewhat different definition of peers, but I think what's common to all of them is that the lived experience is central. But what the actual goal of the peer support intervention does tend to vary from one place to the other. For example, Fountain House, which is in New York City, is working with my lab specifically on a peer-supported intervention, but which is focused on lifestyle changes that can actually reduce the risk of cardiometabolic conditions in people with psychosis. So, you know, what we want to do, we've just received a small philanthropic gift to begin to do a landscaping of all the different peer support interventions. And I really hope separately after this call, you can just shoot me an email so I can be in touch with you and my team can be in touch with you to learn more about what's happening in your backyard. But similarly, we're planning over the coming months to bring together a group of experts. As I mentioned, you know, when we select interventions, we start with a group of experts who already have subject knowledge and who can help us bring all of this together so that we can then examine the need and the mechanisms of actually creating online tools that can be used by a broader communities.
Two questions from the chat. One, just what are some key websites to follow this work? And also, given the focus on digital tools to scale up those interventions, could you address how to overcome the digital divide that seems to already be contributing to health equity issues?
Yeah, well, I'm sorry, I missed the last slide, which has the information that you might want. So that's the website there. The name of the program manager for the lab at the medical school is, you can see her email, you can write to her. And the APA Journal Focus published a paper describing the methods a few months ago. And again, Natalie can share that with you as well. I also wanted to say, I mentioned earlier that the HMS is going to be spinning off an enterprise for Scale Up, and the CEO of that enterprise is Ben Miller. Some of you may have heard of Ben. He used to be the president of the Wellbeing Trust and is now the CEO of this new enterprise. So this is an enterprise that will work in a much more flexible way with implementers on the ground in ways that I think the medical school can't, so that, you know, it can be much more nimble. And so Ben in the coming weeks will also be leading his own initiative to set up this new enterprise in partnership with Harvard.
Great. Let's turn to one of the raised hands, Giorgio Hanvin.
Hi, Dr. Patel. Thank you so much. It was very exciting to hear about this model. I guess I'm curious about also maybe kind of like what Barbara was asking, the compensation for peers and community-based members, and you know, particularly I'm a social worker working with people who are using drugs and substances, and thinking about what their compensation might be, and then also curious about if there's some idea of how to support peers if they're experiencing the same challenges that the people that they would be counseling would be experiencing, meaning if they're living in the same communities.
So Georgia, the two questions, and I thanks for reminding about the financing question. So the financing question is one of those structural questions that one has to address in a case-by-case way, because financing is not the same in every context. Even in Texas alone, which of course is a huge state, there are completely different financing mechanisms depending on which system you're working in. In some cases, you have to get reimbursement code from Medicaid, and others, the community health workers are salaried. And so they work as part of a collaborative care team already, like at Baylor Scott White. And it's a managed care organization. So, it does vary from place to place. And for example, as Barbara mentioned, the peer support workers are financed to a completely different route, like SAMHSA finances it. So one has to work on a case-by-case basis. These are such early days. I can't tell you that there is, a set of solutions that applies everywhere. I don't think it will be like that. In India, for example, the frontline workers are part salaried and part incentivized. So they get paid they get a fixed monthly amount, which is quite modest, but then they can supplement that with casework. So they then get paid for completed treatments. So for example, a certain amount will be paid to you per session, but if you complete the 6-session treatment, then you will get paid like an extra bonus. So in every place, financing of community health workers does vary, but and that is certainly one very important practical question as we are scaling up in the real world. In the context of support, absolutely right. This is where, again, I think this is where the Empower model has paid a lot of attention to continuing lifelong support and supervision. And support is critical, and the support is primarily with your peers. By here, I don't mean a person with a lived experience. What I mean is another person like you who is in the care delivery system and has already been credentialed, and they will actually also be learning how to support one another in this what can be sometimes, obviously quite a stressful piece of work.
Thank you.
Harmeet Singh is up next. Please, you have a question.
Hi, thanks so much for a talk that was so grounded in pragmatism and besides, of course, evidence, as you mentioned. A couple of things, and if I sound a bit cynical, it's only because I'm a good New Yorker, and so I have a skewed view of the world. One is, I think as a field, and by that I mean the mental health field, we haven't done a tremendous job, I think, of educating the public about the value of psychosocial interventions. And instead, perhaps with good reason or not, we focused on sort of what we consider tangible biological therapies. And that, I think, has translated into societal expectations of what psychiatric treatment is or should be. And I think it was best exemplified by a patient that I saw, who I spent an hour with doing an evaluation, suggested a psychosocial intervention. And the response I got was, "You mean I wasted a whole hour talking to you and you're not going to write me a prescription?" I think if we extend that, there is a certain view that Western medicine takes, and I think that we need to overcome that in some way. The other kind of similar but related question is, we haven't done a tremendously good job, and now I mean we as a field of medicine perhaps, of educating primary care or making mental health a large enough portion of the curriculum of a medical student. And I think that poses a significant barrier to some of the tremendous work that you've outlined. So suggestions or ideas or your thoughts on that would be much appreciated. Thank you.
Yeah, thanks, Ramit. I'm being cynical. I think you're being very practical too. I mean, I think, there is a kind of vicious cycle, when people's expectations from mental health care will involve only the deployment of medication, because that's what historically has been the dominant form of care. Therefore, there will be a vicious cycle that's what they'll end up expecting to receive. And if they don't receive that, that will be something which they'd be disappointed by. That being said, there was a great systematic review some years ago on patient preferences in the US. And I wish I could remember the author, but I'm happy to share that with you. But there's a large body of evidence when people are asked if you get both at the same cost and ease of access, which you prefer. It turns out actually a very large majority prefer psychosocial intervention. The problem is people's experience of accessing psychosocial interventions is immensely more difficult than actually accessing a script. So, it isn't so much that they're wishing to have a script because that's what they prefer, but because it's oftentimes a cheaper and quicker solution that the system makes available. To the second point about primary care, I completely agree with you. Primary care is the focus of collaborative care. It is the center of gravity of collaborative care. And in collaborative care, which I'm sure all of you are familiar with, the way it's structured is the mental health specialist or the behavioral specialist typically supporting the primary care provider in a multiple different kinds of ways. What the approach that I'm talking about today really reflects is yet another provider who is actually connected with the primary care provider, but by providing continuing care in the community. So it's the community health worker is a critical provider linked to the collaborative care model.
Thank you. We have a hard stop at 12, but we're going to ask, we'll allow Luca Pacelli, one of our residents in the global mental health track at Mount Sinai, to ask a question.
Thank you. Thank you for the presentation. Amazing. My question is a little bit drier, maybe, than the others. The mental health, global mental health program here at Mount Sinai has been working with our, among other institutions, with the Carter Center in Liberia, and provided CBT training for mental health clinicians. So non-provider, non-psychologists, non-social workers, or physicians that provide care in a country where there are only 2 psychiatrists. I was lucky enough to be selected to go there to do a study to look at the impact of the training, the CBT training, on the mental health clinicians. While it is a small study, I was wondering if you had, and I am putting together the protocol and I'm going through instruments to look at the knowledge and the skills that these mental health clinicians have acquired compared to those that didn't receive the same training. And then I'm adding a part of qualitative study that is, it will look more at their experience and their experience of the training in their day-to-day practice. But my question is, what, I want to make sure that I'm selecting tools that are affecting at detecting what I'm trying to look, because I'm afraid that if I use the best tools to look at CBT in the United States, it's not going to actually be useful. And I know that you mentioned that you did trials of looking at that, and I want to pick your brain on what would you suggest as far as tools.
Okay.
Well, Luca, in the interest of time, maybe we can have this conversation by email. Hopefully Paul will share my email with you. This is a longer conversation. I don't think I'll be able to address these very important questions in the few seconds we have left. But please do get in touch with me by email, and I look forward to having that conversation with you. I also now notice there are many people who have put in chats.
Yeah.
And again, please contact me on my HMS email address. And, for those of you who want to continue the conversation, I'd be very happy to do that.
Thank you so much. I put the Empower link in the chat, and I think you can contact folks there that to connect. People are interested in connections in Toronto and California. So thank you so much for taking the time to join us and for sharing this incredible work. And thank you all for joining, all the people from Mount Sinai and beyond. So
thank you so much. Bye-bye. Have a wonderful rest of your day.
thank you.